Skull, a wooden block is placed under the shoulder. It extends the neck. Head is stabilized by a head rest which has a semicircular groove to hold the back of the neck. Next is hair is then parted with a comb in a line joining the mastoid process, passing over the vertex, and the scalp incised down to the bone along it. The incision should be deep enough to penetrate the periosteum. The two scalpel flaps are then reflected down to the supraciliary ridges in front and to the external occipital protuberance behind. If the reflection is difficult, a scalpel blade can be used to cut the loose connective tissue as the other hand continues to peel the scalp. The knife edge should be directed towards the skull, not towards the scalp. Otherwise, it would create what? Buttonholes. So, should be not into the directed towards the skull, not to the scalp. The anterior flap is reflected. Anterior flap is reflected to a level approximate 2 finger breadth above the supraorbital ridge. The posterior flap is reflected down to a level 2 finger breadth above the occipital protuberance. Not any bruising. Of the deeper tissues of the scalp or injury to the bone. Fracture, not fracture. Not fracture of the top of the skull. Fracture lines can be differentiated from normal suture by one is anatomical position. Streak of blood is seen along the line of fractures. Gently tap gently with a chisel. A fractured skull gives a dull note. Just as one examiner a picture of hidden hack. This technique more useful for dictating fracture at base when they are more deceptive to find once the skull cap is taken out. Two more techniques are useful for detecting fracture. Take a skull cap near window. Place it against a light. Fracture line will be clearly visible. Fill the skull cap with the water. It will leak from the sides of the fracture. Then parotid glands can be examined if necessary by continuing the incision down in front of the ear. Temporal and masseter muscles are cut on either side to enable proper sewing of the skull. Vibrating so does not work too well if soft tissue is attached to the bone. The skull cap is then removed by sewing. The three methods are generally employed. That is straight line. Simplest, but the skull cap can be slip upon reconstruction. V-shaped line skull cap fit back nicely, does not slip in a V-shaped. So line goes from the center of the forehead, P to the base of the mastoid, either side Q. From this point to a 2 finger breadth above the occipital protuberance, that is R. Next is zigzag line. Complex but best. Frontal A is approximate 2 finger breadth above supraorbital ridge. Point B is approximate 2 finger breadth above top of ear in its natural position before scalp reflection. Top of ear. Point C is above B. Occipital point D is approximate 2 finger breadth above external occipital protuberance, that is inion. If A is too low, there is danger of cutting into the roof of the orbit. If B is too low, it will enter pittorous portion of the temporal bone. If D is too low, solein will below attachment of the tendorium. Whatever the method is used, care should be taken to avoid sewing through the meninges and brain. To avoid this, stop when so. Suddenly stops meeting resistance. After this chisel, a hammer should be used to loosen the skull completely. Heavy hammering should be avoided as it creates a false fractures or extends fracture already present. Skull cap can be removed by gently inserting a T-shaped chisel, twisting it. This is done at several points. Examine meninges. Examine the meninges for arachnoid granulation, whitening and glistening, thickening over the buttocks with a small calcified patches are seen in an old person. They give a gritty sensation if palpated with the fingers. Congestion disease, extradural hemorrhage. Description of a hematoma and hemorrhages. Not whether they are spread like a thin film over the brain or localized or to one area only. Not it is solidified, that is hematoma. Still liquid hemorrhages. If a solid or a semi-solid, describe them in terms of grams of weight. Area covered of the brain. Thickness, extradural hematoma present over the left temporoparietal region measuring 4 into 3 into 2 centimeter, weight at 25 gram. Superior sagittal sinus, open it along the length with a scalpel or scissors. Look for antemortem thrombi. Antemortem, look for any antemortem thrombi. Okay. Importance antemortem thrombi in a superior sagittal sinus, back pressure in bridging vein crossing a supradural space, back pressure in bridging vein crossing subdural space rupture, subdural hemorrhages. Then is dural venous sinus thrombosis. Cerebral venous sinus thrombosis. Mean age is between 37 to 38 years. Although all ages can be affected, sex are more common in women, particularly in age group 20 to 35 due to pregnancy, purpurium, oral contraceptive pills. Large sinus such as superior sagittal sinus are most frequently involved. Next is extensive collateral circulation within the cerebral venous system allows for a significant degree of compensation in the early stages of thrombus formation. Predisposing factors, oral contraceptive pills cause in 30% of cases, non-underlying cases can be identified. Infective intracranial lesions, sepsis, systemic infection, non-infective Behçet's disease, connective tissue diseases, cardiac diseases, coagulation disorders like acquired or hereditary. Then certain drugs, asparaginase, L-asparaginase, epsilon aminocaproic acid, ecstasy also. Okay, thrombocyte, ecstasy. Then hormone, inflammatory bowel disease, malignancy, nephrotic syndrome, dehydration, infusion via the central venous catheter, RBC dyscariasis, hemorrhages, stroke, thrombocytopenia, brain occupying lesions, surgery and surgery with immobilization. Next is removal of dura. Dura is now incised on both sides of the superior sagittal sinus along its length. Scalpel is then passed vertically downward along the falx cerebri as its anterior end. Falx is divided where it attached to the crustate galli. With the forceps, dura and falx now pull backward. Inferior sagittal sinus is seen at the free edge of the phalanx. Pass a fine tip needle through it, incise it, look for thrombi in a similar way. Surface of the brain should be identified. Look for hemorrhages underneath the duro. It can be subdural or subarachnoid. Try washing with the water. If it can be washed, it is subdural. If it cannot be, it is subarachnoid pus. Thank you.